Welcome. Today we work through 5 liver diseases that share one problem. None of them announce themselves. You only find them if you go looking. We will cover hereditary hemochromatosis, Wilson disease, Alpha-1 antitrypsin deficiency, primary biliary cholangitis, and primary sclerosing cholangitis. For each one, we will meet a patient, work through the history and the exam, pause on the diagnosis, then reveal the confirmatory test and the next step. Let us start with why these 5 belong together. Here is the situation. Your patient has abnormal liver tests or new cirrhosis. The alcohol history is clean. Hepatitis B and C serologies are negative. There is no metabolic dysfunction to blame. That is the moment these 5 diagnoses matter. Notice that each one has a signature test. Iron studies for hemochromatosis, ceruloplasmin for Wilson disease, a protease inhibitor phenotype for alpha-1 antitrypsin deficiency, the antimitochondrial antibody for primary biliary cholangitis, and a cholangiogram for primary sclerosing cholangitis. Nobody finds these by accident. You have to go looking. Here is what you should take away. First, recognize the 5 diseases to consider when the common causes of liver disease are negative. Second, interpret iron studies and know exactly when a liver biopsy is needed. Third, use ceruloplasmin, urine copper, and the 2 ratios that flag Wilson disease and acute liver failure. Fourth, order the right test for alpha-1 antitrypsin deficiency, and order it the right way. Fifth, treat primary biliary cholangitis and know when to add a second agent. And finally, separate primary biliary cholangitis from primary sclerosing cholangitis and know what cancer you are watching for. Meet our first patient. A 58-year-old man comes in with a year of fatigue he cannot shake. His knuckles ache, both hands. He was told last year that he has type 2 diabetes, and he has lost interest in sex. He does not drink, and his hepatitis B and C serologies are negative. One exam he looks deeply tanned, but he has not been in the sun. His liver edge is firm and palpable, and his testes are small. Notice what is missing. No spider angiomata, no palmar erythema, no ascites. This is not the look of a decompensated cirrhotic. Now the labs. His transaminases are mildly elevated. The alkaline phosphatase and bilirubin are normal. His ferritin is 1,840 nanograms per milliliter, and his transferrin saturation is 68%. The hemoglobin A1C is 8.1%. Ultrasound shows a coarse liver but no mass. Take a moment. The knuckles, the diabetes, the skin, and those iron studies. What is the diagnosis, and what test confirms it? This is hereditary hemochromatosis. In this population, most cases come from mutations in the HFE gene, typically a C282Y homozygote. The screening test is the transferrin saturation, serum iron divided by total iron binding capacity. Anything above 45% should push you forward. Confirm with HFE genotyping. His ferritin is well above 1,000 nanograms per milliliter, so a liver biopsy is indicated to measure the iron index and to stage fibrosis. Then start weekly phlebotomy. His diabetes, his knuckles, and his skin all come from the same iron. Step back and look at the mechanism. At the top is the common endpoint, iron deposited in tissue. Hemochromatosis is a recessive disorder of iron sensing or iron transport. Follow the first branch. HFE mutations account for about 85% of cases, usually C282Y homozygosity, rarely a compound heterozygote carrying H63D. The middle branch is the non-HFE group, hemojuvelin, hepcidin, transferrin receptor 2, and ferroportin. The third branch is secondary iron overload, iron-loading anemias, repeated transfusions, long-term dialysis, chronic liver disease, and dietary iron. These numbers matter because the gene is common and the disease is not. About 0.5% of Northern Europeans are C282Y homozygotes, but only 28% of homozygous men and 1% of homozygous women ever develop iron overload. Why the difference? Menstrual blood loss lowers the iron burden, so women present later, if at all. And in compound heterozygotes, carrying one C282Y and one H63D, only 1.5% manifest iron overload. The lesson: a positive genotype is not a diagnosis. You still need the iron studies. So what does the iron actually do? Early on, patients feel tired, their joints ache, and men lose libido. Advanced disease is genuinely rare now. But when it happens, the skin turns bronze from a mix of melanin and iron. The pancreas fails and diabetes follows. The metacarpophalangeal joints, the big knuckles, become arthritic, and the heart develops a cardiomyopathy. The liver progresses to cirrhosis, and that carries a 15% risk of hepatocellular carcinoma. Alcohol and fatty liver make that worse. One more thing. Iron feeds certain organisms. Vibrio, Listeria, and Yersinia. Here is the pathway. Step 1. Calculate the transferrin saturation, serum iron divided by total iron binding capacity times 100. Above 45% is abnormal. Step 2. If the saturation is high, send HFE genotyping to confirm. Step 3. Check the ferritin and the liver enzymes. Remember, ferritin is an acute phase reactant, so it is not specific, and it is often normal in younger patients. Step 4. If HFE is positive and the ferritin is above 1,000 nanograms per milliliter, or the liver enzymes are up, do a liver biopsy for the quantitative iron index and to stage fibrosis. Treatment is mechanical, and it works. Remove blood. 250 milliliters is 1 unit, and it takes about 250 milligrams of iron with it. Do that weekly. Your targets are an iron saturation under 50% and a ferritin between 50 and 100 nanograms per milliliter. Then move to maintenance phlebotomy every 3 to 4 months. A proton pump inhibitor reduces intestinal iron absorption and may reduce how often you need to draw. Tell patients to avoid vitamin C supplements and uncooked seafood. If phlebotomy is contraindicated, use deferoxamine and offer genetic counseling. Our second patient is a 24-year-old woman. 3 months of fatigue and yellow eyes. Her handwriting has changed and her hands shake. Her family says she has become irritable and is failing her classes. She does not drink, and she has taken no acetaminophen and no herbal supplements. On exam, she is icteric. She has a coarse tremor, both at rest and with posture. The spleen tip is palpable. And on slit lamp examination, the ophthalmologist sees golden brown rings at the edge of the cornea. Hold on to that finding. Now her labs. The AST is 210, and the ALT is 88. Look at that ratio. The alkaline phosphatase is only 24, which is strikingly low for someone whose bilirubin is 7.2. She has a hemolytic anemia with a hemoglobin of 9.2, and the Coombs test is negative. Her INR is 1.6. Viral hepatitis and autoimmune panels are negative. A young woman, neurologic change, hemolysis, and a failing liver. What is the diagnosis, and what confirms it? This is Wilson disease, a recessive disorder of copper transport caused by mutations in the ATP7B gene. Confirm it with a low serum ceruloplasmin and a high 24-hour urinary copper. Those golden brown rings are Kayser-Fleischer rings, copper deposited in the cornea. The combination of Coombs-negative hemolysis with a disproportionately low alkaline phosphatase is the classic clue. Her ratios fit too. Alkaline phosphatase to bilirubin is under 4, and AST to ALT is above 2.2. Star chelation, and involve the transplant team early because her INR is rising. Let us walk through why the copper builds up. Step 1. The ATP7B transporter inside the hepatocyte fails. Step 2. Copper can no longer be moved into bile, and bile is the only meaningful route the body has for getting rid of it. Step 3. Copper accumulates inside liver cells, producing hepatitis, then fibrosis, then cirrhosis. Step 4. When the hepatocyte is overwhelmed, free copper spills into the blood and lands in the brain, the cornea, and the red cells. That spillover is why one disease produces a movement disorder, a corneal ring, and a hemolytic anemia all at once. 3 numbers to keep. Wilson disease affects about 1 in 30,000 people. The age at presentation generally ranges from 3 to 55 years, which is why unexplained liver disease anywhere in that range deserves a ceruloplasmin. And Kayser-Fleischer rings are present in 99% of patients who have neurologic or psychiatric disease, but in fewer than half of those without it. So the absence of rings never rules Wilson out in a patient whose disease is confined to the liver. That is the mistake to avoid. Wilson is not only a liver disease. The neuropsychiatric presentation is the one that gets missed. Personality change, depression, even psychosis. Patients develop Parkinsonism and abnormal movements, which is why the old name was hepatolenticular degeneration, the liver and the lenticular nucleus of the brain. Kayser-Fleischer rings sit at the corneal limbus and need a slit lamp to see. The hemolytic anemia is Coombs-negative because it is copper, not antibody, destroying the red cells. And the kidneys can show tubular dysfunction. Young patient, liver disease, psychiatric change. Think copper. Here is the workup in order. Start with a serum ceruloplasmin. It is low in Wilson disease with a sensitivity of about 90%. Then collect a 24-hour urine for copper, which is elevated. Ask for a slit lamp examination for Kayser-Fleischer rings. If the picture is still unclear, a liver biopsy measures hepatic copper content, and genetic testing for ATP7B can settle it. Now the special case. In acute liver failure, an alkaline phosphatase to bilirubin ratio under 4, plus an AST to ALT ratio above 2.2, performs better than either urine copper or ceruloplasmin. Treatment is chelation. D-penicillamine binds copper and pulls it out. Supplement vitamin B6, because D-penicillamine inactivates it. Trientine is the alternative. Less toxic with roughly equal efficacy, but expensive. Zinc works differently. It blocks copper uptake from the gut and can help delay disease. Use it alongside a chelator and give it 5 hours after the chelator so the two do not bind each other. Eliminate copper-rich foods. Transplant is for acute liver failure or for disease that does not respond. And an investigational agent, bischoline tetrathiomolybdate, may slow neurologic decline compared with trientine. Our third patient is a 44-year-old man. His liver enzymes came back abnormal on a routine panel. He also mentions 2 years of breathlessness when he exerts himself. He has never smoked. He does not drink. His body mass index is 24, and his viral serologies are negative. On exam, his chest is barrel-shaped, and his breath sounds are quiet at the bases. His liver edge is firm. He is not jaundiced, and he has no stigmata of chronic liver disease. So we have a liver problem and a lung problem in the same never smoker. His labs show mildly elevated transaminases and a normal bilirubin. His platelet count is 128, which is low, and that hints at portal hypertension. Spirometry shows an obstructive pattern with a ratio of 0.58, and the diffusing capacity is reduced. The chest CT shows emphysema at the lung bases. Remember, he has never smoked a cigarette. What single condition ties the liver and the lung together? This is Alpha-1 antitrypsin deficiency. The confirmatory work is simple. Send a serum Alpha-1 antitrypsin level and send a C-reactive protein with it. Alpha-1 antitrypsin is an acute phase reactant, so inflammation can push a deficient level up into the normal range and fool you. The gold standard is phenotyping of the protease inhibitor system, written as PI. Our patient is a ZZ phenotype. And here is the teaching point. Emphysema in a never smoker should make you order this test every time. This slide is the whole disease in one picture. On the left, the liver. The abnormal protein folds badly and polymerizes inside the hepatocyte. It cannot get out, and what stays behind injures the cell. That produces neonatal hepatitis, cholestatic jaundice in children, and elevated transaminases or cirrhosis in children and adults. On biopsy, you see characteristic PAS-positive cytoplasmic inclusion bodies. Now the right side. Because the protein never leaves the liver, very little reaches the lung. Neutrophil elastase goes unopposed and digests alveolar walls, producing panlobular emphysema. Now the numbers. Alpha-1 antitrypsin deficiency affects about 1 in 3,000 people of European ancestry, which makes it far more common than most of us assume. The Z allele is the one most tied to liver disease. 63% of ZZ adults have chronic liver disease. And here is the number that should change how you think. 35% of ZZ adults who have no overt liver disease at all still have fibrosis. Rarer associations include SZ heterozygotes and the M. Malton variant. So how do you make the diagnosis? First, send the serum Alpha-1 antitrypsin level. Second, send a C-reactive protein at the same time. If the C-reactive protein is high, a normal Alpha-1 antitrypsin level is not reassuring because inflammation may have lifted it. Third, the gold standard is protease inhibitor phenotyping, which tells you which alleles the patient actually carries. The Z allele is the one most associated with hepatic disease. And if a biopsy is done, the finding is PAS-positive cytoplasmic inclusion bodies. Presentations run from neonatal hepatitis all the way to adult cirrhosis. There is no liver-specific drug yet, so management is about protecting the liver he has. Alcohol is out completely. Keep the body mass index in the normal range, because fatty liver adds a second insult. If disease becomes severe, liver transplantation is the definitive treatment. Be clear with patients about one point. Intravenous augmentation therapy treats the lung disease. It does not treat the liver. Agents aimed at the liver disease are under study. And counsel hard against smoking. Nothing accelerates the lung disease faster. Our fourth patient is a 54-year-old woman. She has itched for 6 months, worse at night, and it is wearing her down. She's exhausted and sleeps badly. Her history includes hypothyroidism, and she describes dry eyes and a dry mouth. She has started no new medication. She is not jaundiced. On exam, she has scratch marks across her arms and back, a mildly enlarged liver, and yellow plaques at the inner corners of her eyelids, which are xanthelasma. Keep the autoimmune company she keeps in mind. Her labs show a striking pattern. The alkaline phosphatase is 412, while the transaminases are only mildly elevated. The bilirubin is normal at 1.1. Her immunoglobulin M is elevated. Her total cholesterol is 288, and most of it is HDL. Ultrasound shows normal bile ducts, no obstruction, no stones. So this is intrahepatic cholestasis in a middle-aged woman with itching and autoimmune disease. What single antibody makes the diagnosis? This is primary biliary cholangitis, an autoimmune destruction of the intrahepatic bile ducts. The antimitochondrial antibody is positive in about 95% of patients. And here is the practical point. When that antibody is positive and the biochemical pattern fits, You do not need a liver biopsy because the antibody has high sensitivity and specificity. Her other conditions fit too. Thyroid disease and Sjogren's syndrome travel with this disease, and Sjogren is present in about half of patients. Next steps: start ursodeoxycholic acid and treat the itch, because that is what is actually bothering her. 3 numbers to hold on to. The anti-mitochondrial antibody is positive in 95% of patients with primary biliary cholangitis. About half of patients are asymptomatic and are found only because their liver tests are abnormal. And here is an interesting one. Roughly 0.5% of the general population has a positive anti-mitochondrial antibody with normal liver tests. 10% of those people go on to develop the disease by 6 years. So a positive antibody by itself is not the disease. It is a risk marker. The typical patient is a woman between 40 and 60. Here is the biochemical fingerprint. The alkaline phosphatase is the dominant abnormality. The bilirubin rises later, and when it does, it signals advancing disease. Immunoglobulin M is elevated. The cholesterol is high, mainly the HDL fraction, and the anti-mitochondrial antibody is positive in 95%. If that antibody is negative but everything else fits, do a liver biopsy. Those patients often have a positive antinuclear antibody or smooth muscle antibody, and importantly, their prognosis is the same. Before you commit, exclude sclerosing cholangitis, autoimmune hepatitis, sarcoidosis, drug injury and obstruction. Treatment starts with ursodeoxycholic acid. Guidance from the American Association for the Study of Liver Diseases gives 13 to 15 milligrams per kilogram per day, which may be given in divided doses. Recheck the biochemistry at 3 to 6 months, because the biochemical response predicts the clinical outcome. About 25% of patients have a complete response, and treatment improves survival, reduces histologic progression, and reduces complications. If the response is inadequate, add a PPAR agonist, elafibranor or seladelpar, either with the ursodeoxycholic acid or alone if the patient cannot tolerate it. Bezafibrate is a second-line option in combination. Now the itch, because it drives quality of life. First line is cholestyramine, and timing matters. Give it 2 to 4 hours after the ursodeoxycholic acid, so it does not bind it. If the itch is refractory, the options are renaltrexone, rifampin, or pheresis. A caution on obeticholic acid. It is a farnesoid X receptor agonist that is falling out of favor, partly because it makes pruritus worse. The PAR agonists cannot be used in decompensated cirrhosis. And for end-stage disease, transplantation works. About 20% recur, but recurrence does not affect long-term survival. Our last patient is a 32-year-old man. He has been tired and itchy, on and off. He has had ulcerative colitis for 6 years, and it is currently quiet. Twice in the past year, he has had right upper quadrant pain with a low-grade fever that settled on its own. Between those episodes, he is not jaundiced. Today, he has mild scleral icterus, tenderness in the right upper quadrant, and an enlarged liver. No ascites, colitis plus cholestasis. That pairing should already be pointing you somewhere. His alkaline phosphatase is 520. The transaminases are mildly up, and his bilirubin is 2.4. The anti-mitochondrial antibody is negative. His immunoglobulin G4 level is normal. A right upper quadrant ultrasound shows no stones and no dilated ducts. So we have cholestasis, with a negative antibody and an unrevealing ultrasound, in a young man with ulcerative colitis. What imaging study makes the diagnosis? This is primary sclerosing cholangitis. The diagnostic test is cholangiography, magnetic resonance cholangiopancreatography, or MRCP, and it shows multifocal beaded strictures of the bile ducts. Unlike primary biliary cholangitis, this disease inflames both the intrahepatic and the extrahepatic ducts, leading to fibrosis and stricturing of the whole biliary system. About 70% of patients with this disease have inflammatory bowel disease, usually ulcerative colitis. Before you commit, exclude secondary causes, then start him on a surveillance plan. The bowel connection is the defining epidemiologic fact. About 70% of patients with primary sclerosing cholangitis have inflammatory bowel disease, usually ulcerative colitis. Run it the other way, and the number is small. Only 1 to 4% of patients with ulcerative colitis have this disease. And half of patients are asymptomatic at diagnosis, found on liver tests alone. The typical patient is a man between 20 and 50, which is the mirror image of primary biliary cholangitis. The disease is also associated with HLA-B8 and with DR3 or DR4. Here is the diagnostic sequence. Step 1. A cholestatic pattern. A high alkaline phosphatase, often with fatigue and itching, sometimes fevers or right upper quadrant pain. Step 2. Imaging. MRCP is the test of choice, and endoscopic retrograde cholangiopancreatography is added when you need to intervene. You are looking for multifocal beaded strictures. Step 3. Exclude secondary causes and immunoglobulin G4, autoimmune cholangitis. Step 4. If imaging is unrevealing but suspicion remains, biopsy. The classic finding is onion skin fibrosis around the bile ducts. Now the hard truth about treatment. No medication has been shown to improve survival in primary sclerosing cholangitis. Ursodeoxycholic acid may lower the alkaline phosphatase and improve symptoms, but whether it changes outcome is unclear. So the work is supportive. Treat the pruritus, replace the fat-soluble vitamins, and watch for cholangitis. If a dominant stricture develops, the options are endoscopic dilation, stenting, or surgical resection. Foreign-stage disease, transplantation, recurrence is around 30%, and in ulcerative colitis, colectomy may reduce that recurrence. This is the complication that defines follow-up. Cholangiocarcinoma carries a 15% lifetime risk in primary sclerosing cholangitis. That is high enough that surveillance is routine. Perform annual imaging with MRCP or ultrasound, along with the CA19-9. And do not forget the colon. Patients who also have inflammatory bowel disease carry a higher colorectal cancer risk, so surveillance colonoscopy has to stay on schedule. One more rule. If a new dominant stricture appears, treat it as malignant until it is proven otherwise. This is the slide to remember. On the left, primary biliary cholangitis, women, typically 40 to 60, small intrahepatic ducts only, antimitochondrial antibody positive in 95%, diagnosis by antibody, so biopsy is rarely needed, and ursodeoxycholic acid improves survival. On the right, primary sclerosing cholangitis, men, typically 20 to 50, both intrahepatic and extrahepatic ducts. About 70% have inflammatory bowel disease. Diagnosis by cholangiogram showing beaded strictures, and no drug improves survival. Both itch. The antibody and the cholangiogram tell them apart. 6 traps before we finish. 1. A normal ferritin does not exclude iron overload in a young patient. It is an acute phase reactant, and it is often normal early. 2. Ceruloplasmin is normal in about 10% of Wilson disease, so a normal value does not close the case. 3. Emphysema in a never smoker means you check Alpha-1 antitrypsin. 4. Always pair that level with a C-reactive protein, because inflammation can mask a deficient level. 5. An antibody-negative patient can still have primary biliary cholangitis. And 6. A normal MRCP does not exclude small duct sclerosing cholangitis. These are the published sources behind what we covered. The major reviews on hemochromatosis, Wilson disease, Alpha-1 antitrypsin deficiency, primary biliary cholangitis, and primary sclerosing cholangitis, along with the trial reports for the newer agents in primary biliary cholangitis. Always check management against current guidance from the American Association for the Study of Liver Diseases and the European Association for the Study of the Liver. Thanks for working through these 5 with me.